Hello, everybody. This is Ted, your instructor for perioperative nursing. I just wanted to do a quick overview of perioperative nursing for you today. This overview is probably the only PowerPoint that you will be getting from me during this course, but I wanted you to be prepared for starting to really dive into the first module of perioperative nursing and to look at what we truly are. So when we look at perioperative nursing, we say perioperative because it is more than just in the OR. So it's preoperative, intraoperative, and postoperative. What we want to do is make sure that when we say perioperative, we understand that it includes all three areas of care. Now, intraoperative is that OR piece. Preoperative, you might have some about 30 seconds of FAME in, and postoperative is typically PACU, or post-anesthesia care, which can in itself be its own discipline, but in some places, the perioperative nurse may do all three areas. When we think about patient outcomes, what we want to do is think about the fact that our patients will be free from injury and infection. So when they come to us, we want them to leave having the intended procedure that they were supposed to have and not to come back to us with an infection. And sometimes, as sick as our patients are these days, they may have an infection at the end that there's nothing we could do to prevent. But we want to look at these things and do everything in our power to prevent them from happening. We want to make sure that we're looking at the appropriate use of medication. And believe me, there's not the same medication administration on the floor as there is in the operating room. You're not going to be giving IV medicine. You're not going to be giving oral medicine. You're going to be putting all types of different medications onto the sterile field that you may not be familiar with. There's going to be a steep learning curve there, and a lot of the medications are very dangerous that we use. All the systems that the patient has, so their motion, their vital signs, their feeling, all should be either the same or better than baseline whenever they leave. Their pain has to be controlled. All of you have heard about narcotics in the news and the fact that we can't rely on narcotics anymore the way we used to. So we really have to make sure that that patient participates and is engaged and understands the process, knows what the pain is going to be, and knows how to control that pain. Now, the roles of the perioperative nurse are many. You have a circulating nurse. You have a scrub nurse. You have the role of patient advocate. You have the role as friend. You have the role to be the person to do the patient assessment and the patient teaching. You have to control the environment. That circulating nurse in the operating room, controlling the environment, making sure that we have what we need and that patient is safe is their number one concern. You must work as a team in the perioperative environment, and sometimes that can be very challenging. However, working as a team is working with your anesthesia provider, your surgeon, your PA, your technician, your nurse practitioner. Everybody has to work together. And then, goodness gracious, we have all the reps, which we'll talk about later. And then you have professional responsibilities. And by professional responsibilities, ANA, Code of Ethics, yes, we do mean that. But what I'm really talking about are things like joining your professional organization, which if you were an OR nurse would be AORN, the Association of Perioperative Registered Nurses. And then eventually at your 2-year mark, become certified as a perioperative nurse, which shows recognition that you have the skills and the abilities to be a nurse in those areas. Now, just to touch briefly on advanced practice is controlled by the state. I'm sure you've had classes about advanced practice and about how the state law decides what advanced practice is. Almost all 50 states now have decided on the same model for advanced practice. Most advanced practice is turning into a doctorate level for entry level into practice. I entered advanced practice with a master's level, and at that time was considered to be the entry level into practice and have been grandfathered, but that process is changing. Now, to be clear, a registered nurse first assist or a certified registered nurse first assist is not advanced practice. They are additional roles. They do require additional training. However, they do not carry a license, and they are not considered to be advanced practice beyond their basic RN license. Our practice settings. We've got hospitals. Hospitals do inpatient and day surgery. They have about 90% of their caseload is day surgery, 10% is inpatient. Of the inpatient, about 10% will stay greater than 3 days. The rest will stay less than 3 days. So as you can tell, it's a very fast-paced movement for that patient through the system. Now we also have surgery centers, which essentially do day surgery, but I now see surgery centers keeping patients overnight. We have providers' offices that do surgery, and in some places, I have not seen it in Alaska, we have mobile facilities. Now, when we look at these, all of them are accredited either by the Joint Commission for Accreditation of Healthcare Organizations, or they're also accredited by the AAAHC, which is the Ambulatory Association for Accreditation of Healthcare Facilities. Finally, the members of the surgical team. You've got the sterile members and the non-sterile members. Don't forget about the technician who is cleaning the room between cases, because they're members of that team too. Don't forget about the rep who's there to help the provider either with a new medication, a new implant, a new instrument system. But also remember that those reps don't work at that hospital, and those reps are not licensed at that hospital. That responsibility goes back to you as a circulator. I need to talk briefly about never events. 2 never events for the operating room are wrong site surgery and unintended retained foreign objects. So we do a timeout right before the knife hits the skin to make sure we have the right patient, that we have the right procedure, that we have everything that we need to do the case. And then we also count in the beginning and at the end, sometimes 2 or 3 times at the end, to make sure that that patient doesn't leave with anything that they didn't come in with. So I just want to say thanks for taking the time to listen to this presentation. I want you to have success for Module 1. I want you to think about what you would assess preoperatively when you're looking at doing your presentation and how quickly 2 minutes goes by. Name, date of birth, so you know who they are, what procedure they're having done. Do you have a consent? Do you have lab work? Do you have a history and physical? Who's taking you home? All kinds of things. Do you have any teaching to do? What's the procedure? So lots to think about with that. I want you to think about what a perioperative nurse is, what the professional requirement should be. And, you know, overall, I really want you to make sure that you are having a great experience as you start to venture in to the role of perioperative nursing.